George is a Greek, and although he is the son of mortals, George, according to Homer, was the bravest, the handsomest, greatest warrior of the army of Abimed in the Trojan War. So the irony, when I looked for a Syrian hero, because I am Syrian, I found this guy, 3,500 or status of refugee. And the irony is like not lost on people who know what's happening in Syria. Half the population is refugee now. So that's it. I like to point out, George was butt naked with a diaper rash. So if you really have a patient with cardiogenic shock, okay, you really need power. You cannot depend on a piddly device that would not provide you with enough support. If you have a large-sized person, you really have a significant hemodynamic deficit. This patient needs 4 to 5 liters to support him. He cannot be supported with 2 or 3 liters. So you need to think of heavier device than the Impella. And I agree, ECMO has no randomized trials. However, there are really credible studies that show that ECMO is actually supportive. And these patients who come with a cardiogenic shock, their choice is either dying or have a hemodynamic support, and their survival of 50, 60%, but that's beats the heck out of 100% death. And I'd like to point out, although ECMO does not have data randomized trial, we do have randomized trials for Impella, right? This is actually balloon pump study that showed the balloon pump does not show any benefit in cardiogenic shock. This is actually comparing Impella to balloon pump, and also Impella to balloon pump has no benefit in those patients who have hemodynamic support. So most importantly, the difference is real support versus no support. And actually, I couldn't put it any better, and thank you, Ajay, for arguing my point, because when his patient blood pressure was 200 with a 3-vessel disease, he put an Impella, right? But the second patient he showed that has 0 blood flow to the heart, Ajay and his really team of luminaries, like this is Colombia for God's sake, they put ECMO, right? And both patients survived, but probably because the hemodynamic deficit, they measured the therapy to the hemodynamic deficit. So the difference, ECMO can provide you 4 to 5 liters per minute of actual cardiac output, in addition to whatever the heart can muster up and pump. While you have to remember, when you put an Impella and you read in the council 3.5 or 3, this is actually algorithm calculated, not actually calculated, as opposed to ECMO. The second thing, you have to subtract that from the cardiac output. Really, that's not the actual cardiac output. It's not like if the cardiac output was a 3 at baseline, you put an ECMO, it becomes 6. Because what happened, the ECMO, as George pointed out, it's actually unload the ventricle, so you have less workload, but not actual hemodynamic support. The ECMO is independent of the heart function. So if you have a VT, if you have a RV failure, the ECMO is going to continue to support, where Impella does not really have a support in patients who have VT. You can actually talk to the patient while they have VFib on ECMO, even in patient with cardiac arrest. So patient with a profound cardiogenic shock, you really cannot depend on an Impella. Most importantly, those patients who have lung injury. A lot of our patients develop pulmonary edema. They need oxygenation, so ECMO will work. And when you have biventricular failure, ECMO will work. And admittedly, I would say ECMO is associated with increased complications, access site complications, but ECMO comes with actually solution for the limb ischemia. If you notice here, there is a side port here. I don't know if you can see my, okay, you can. Side port that actually goes to antegrade sheath, and look at the leg here is very, very pink, where it's actually very difficult to do that with Impella. So what the truth about Impella, everybody using Impella, 75,000 devices deployed, not a single randomized trial in cardiogenic shock, really. And even in a protected PCI, Actually, the trial was negative. It's only post-hoc analysis and 90 days and per treatment arm that showed benefit. So in reality, the emperor is naked. I gotta click escape. Oh. Okay.
Great, definitely the debate has heated up. There's no question about that. So, well, I mean, we have to concede some fights around the areas of the battlefield, and clearly the oxygenation was identified an area that I'm not really fighting about that in those mountains, so to speak, since we're in Colorado. But as we talk about the battlefield, we also have to understand how the troops are approaching the battlefield. And although there is a lot of cardiac output delivered by these cannulas of the VA ECMO, those cannulas are actually delivered in the iliac arteries, or maybe the distal abdominal aorta. In my reading of anatomy, the blood was supposed to go the other way. It was supposed to go from top to bottom. So right now we're having this flow, but it kind of goes from bottom up. And there is a situation there that the last place to reach is actually the ascending aorta, the coronary arteries, and even the innominate artery, which is extremely important circulations of the brain, and the heart may actually not end up getting or realizing that much flow that is delivered in the distal abdominal aorta or the iliac artery. All right. So that's why one can see if the possibility of adding an Impella to ECMO, if all that's so great in the ECMO, then why would Impella make any much difference in the outcomes? It shouldn't. Apparently there is, because it addresses this part that I said before regarding the enhancement of the coronary perfusion pressure by decreasing the LVDP and thereby enhancing its difference from the diastolic blood pressure. Because there may be a lot of power even in a lion, but I do recall from elementary school the myth of Aesop that even little mouse was able to entrap the big lion in order to escape the net that it had captured it. So again, you need, I think, a very smart way. No, power is not everything. How you apply to it and how you combine it is the key. Therefore, I think we have to focus on the hemodynamic support of how much support is necessary at a certain part of the patient's treatment. How can we prioritize the device use? And if we had a good way to actually remove Impella sheath, and when needed, supplement on site with a VA ECMO possibility, that exchange might have led to significantly higher increase of both devices, I think. Which patients should get upfront treatment with an LVAD? What is the optimal use of Impella support, standalone or in combination with the RVAD? How do we manage the biventricular failure? And I'm coming a full circle that none of these situations are ever going to be solved because they're complex and complicated and interrelated, and we have to start dealing with, again, the very first slide. That's why I have an inter-society initiative, other initiatives to try to figure out what are the stages of shock that we can all agree, so we can stop lumping in terminal shock in our trials and claiming no difference. If the shock is terminal, nothing could help those patients, or very little perhaps, or a palliative care consult may be more appropriate. And therefore, we can figure out on the risk factors of mortality the appropriate risk scoring. We have to start to routinely measure these parameters, and we start to make some progress in a regimented way. Thank you for your attention.
All right. So I think I won the debate for just the mere fact that George is so smart, he used long sentences. I am just kind of Joe Schmo who bust arteries open, and I use short sentences. So I gotta admit that the hemodynamic support by ECMO, if you actually able to use the 5.0, it actually provide excellent support, and we are just going to publish a paper about transcaval access 5.0 Impella, and this is to provide enough support. And that actually proved my point that available CP ECMO and 2.5 ECMO might not be enough in those patients who have significant hemodynamic deficit. But how I see it nowadays is not ECMO versus Impella. George could not say it more elegantly. It's actually, we have to work together to save the patient. And a lot of those patients, when the ECMO goes in, there is significant ventricular loading and increased wall tension, which actually gonna cause significant increase in oxygen consumption and oxygen need. So if you add an ECMO if you add ECMO to Impella, now we have a new term, call it Impella, and that actually a lot of times works better for the patients. At the end of the day, this is the cardiogenic shock is a spectrum. There is a pre-shock, and there is shock, and there is shock, and there is deep shock, and so we're really still scratching the surface. And if it wasn't for Navin, Kapur, and Bill O'Neill, and Harry, and the other guys' work, we would not probably start this journey. And soon enough, we're going to have much more data, and just keep tuned. Thank you so much.
Any other comments from the panel before we move on, or any questions for our speakers? All right, hearing none, I think we'll move on to our final speaker. I'd like to invite Dr. Cohen up to speak about the importance of the shock team.
Thank you so much. It's great to be here. I think the shock team has become very important because all these machines that were discussed, they require significant attention and vigilance and expert skills. So most of the things that you need, you can find in this statement that we put together last year, published and led by Sean Van Diepen from Alberta in Canada. So, and we, in this statement, even though we don't dictate any type of guidance, or we don't dictate what should be done, at least we've raised some of the issues that can be taken into consideration. So one of the important things we need to understand is that there's a volume outcome relationship in the management of cardiogenic shock. These volume outcome relationships have been studied first in surgical procedures. Now it's been studied with surgeons. We studied with PCI. It's a little bit controversial, especially in a country that does very little with operators that do very little PCI. But you can see here that using more than 106 cases as a reference, the mortality here is 34.4%, and it goes 10% higher to a hospital that treat less than 28 cases per year. So that's an important thing to consider. So why would that be? Because large volume sites are more likely to be academic, located in urban areas, and probably serve as referral hubs. And that's the first thing that I'm trying to hint, is that the spoke and hub model may be a good model to go to develop these teams. Patients at high volume hospitals are more likely to receive evidence-based care, prompt revascularization by high volume operators, and this is what you need. You need expert operators to take care of these very sick patients. High volume hospitals may include multidisciplinary teams who more frequently implement mechanical circulatory support, as the devices that were discussed here by Carl and George, and can care more efficiently for patients with multi-system organ failure. And then high-volume hospitals can be hubs that are integrated with EMS and spoke centers with clearly defined protocols for early recognition, management, and transfer that can improve patient outcomes. So the guidelines have not been very helpful, and I'm glad that there are some initiatives by the societies. But what we do know about the management of shock is that it's important to revascularize irrespective of time delays, and that's a Class 1B indication based on the shock trial that was done like 15 years ago or more. The use of balloon pump is highlighted in this guideline, but there's not much about alternative devices, or there's not a description of alternative devices for refractory shock. This. And then what to do about these patients? They recommend transfer to a PCI-capable hospital for coronary angiography in patients that develop cardiogenic shock, but they don't go beyond what is PCI-capable. I mean, a small hospital is PCI-capable nowadays. So there's no additional guidance for patients who develop refractory shock after primary PCI and insertion of a support device. So all the development of teams, these are data from the shock trial on transfer. And so a significant proportion of patients were transferred within that trial. And in the IVP arm, 77% were direct admit, 53% were transferred. And in the revascularization arm, 42% were transferred and 58% were direct admit. And those patients that were transferred tended to be a little bit younger, a little bit healthier, but they did well after transfer. So that hub and spoke model can work for the management of shock. We have learned from post-cardiotomy cardiogenic shock with Bridge to Transplant Network that was developed in New York. This was published a few years ago, in where they take patients with LVADs and they send them to more complex programs. I mean, the cases are not that many, but highlights the need of teams that can work on the transfer of these critically ill patients, and how the communications need to be established between the referring center and the referral center. So they developed their own protocols as a bridge to transplant network, and they found that that's associated with improved survival, and they have their own protocols, as you can see there. Then there's another system that was used by the group in Mayo Clinic in Phoenix, in Arizona, where they deploy a team to the spoke hospital, and then they can stabilize the patient, put the patient on mechanical support, either Centromag, Impella, Tandem Heart, ECMO, and then they can transfer to the hub hospital where the patient can receive more care. So this is the timeline. So they have a patient with an adverse cardiopulmonary event, then the consultation goes on, then the approval for emergency privileges and insurance is obtained, decision made for the traveling team. The team arrives in the referring hospital, and then they decide what to do, and then the patient is returned to the hub hospital for a recovery versus transplant. Similar thing has been done in Paris with the cardiac rescue program, where they have special mobile units that can deploy a team, insert mechanical circulatory support, and then transfer to a hub hospital. They developed a form just to measure what they do, because this is very important. And in that program, the mortality of patients of more than 62 years was high, 100%. Patients that had to have resuscitation had high mortality, but the other patients, the patients that survived, had a survival of 93.8% at 1 year. So that highlights the importance of those critical early moments and having teams that can care for these patients. So for the scientific statement, we developed this graph that shows that there are many ways to get to the hub cardiogenic shock center, and there are multiple team interactions. See that we're all men in this panel here, so somebody looked at this slide and changed it and have a female referring in the receiving end of the hub hospital. So anyway, so patients can come from the ambulance, from the field. They can go for the non-shock spoke center, or they can go to a not PCI capable. And there are many ways, but it's important that the shock mobile unit will, and the two teams will establish communication and then decide on what to do with the patient and have expert care. There are also some issues on the training that doctors have in the teams caring for patients. So there's been an appraisal of the need for critical care training for coronary care for the CCU doctors. And this is something that is becoming more important. So it seems that a closed unit staffing model is associated with improved outcomes. The cardiac ICU seems to be best suited to centralize the cardiac care of cardiogenic shock patients, but attending cardiologists and teams may not have the dedicated training to address multi-organ system failure associated with cardiogenic shock. On the other side, the controversy is that MICU may be better suited for management non-cardiac organ failure, but then the MICU trainees are not prepared to manage cardiovascular illnesses and perform common cardiovascular procedures. So there's an emerging evidence that transition from an open, low-intensity care model to a closed unit model with care led by dual-trained cardiologists, intensivists may improve outcomes, and that highlights some aspects of the team. So these are models of staffing for the CICU or ICU according to the hospital. So what we should aim at is to have, if we're going to care for patients with cardiogenic shock, is a high-volume cardiovascular center with around-the-clock house unit coverage by MDs, residents, PAs, nurse practitioners, 1-to-1 nurse-to-patient ratio, mechanical ventilation, invasive cardiac monitoring, transvenous pacing, all sorts of support devices, medical consultants that are available and are on site, and then ancillary personnel, physical therapy, occupational therapy, social work, and then end-of-life decisions are very important, and we need to have a very strong palliative care team. In the end, we have to be careful on how we go about public reporting, because that can deter doctors on how to deal with these patients, and then they may tend to undertreat because nobody wants to be nailed for having a bad outcome in a patient that was sick in the first place. So one solution has been to take these patients away from public reporting, and I think that the National Cardiogenic Shock Initiative is a wonderful initiative to start protocols around the country and improve training and discuss the care of these patients. So in conclusion, I think that cardiogenic care requires a dedicated teams that can translate the success of Mission Lifeline for STEMI and out-of-hospital cardiac arrest with single activation. There's a volume outcome relationship, so we should concentrate the care at high volume centers with trained, proficient staff. CIC models of care are in transition, and the critical care training is needed for cardiovascular specialists. Transfer for cardiogenic shock is possible and associated with good outcomes, and I think new quality initiatives across the country can introduce protocols, collect data, and standardize care. Thank you so much.
Thank you. Are there any questions from the audience? Otherwise, I have one. I'm just curious about, in your center, how do you have the structure with the CVICU? Do you have dedicated cardiac intensivists? Do you have dual boarded people? How does your center do this?
So we are a 3-hospital campus. So we have a VA, a university hospital, and a county hospital. The county hospital has a transplant program, and the transplant unit and that special CICU that is mostly surgically led with anesthesiologists and intensivists is the way that it goes. We have not transitioned yet, and we have not found yet the way to transition to a CICU, a cardiac care unit with dual boarded dual-boarded stuff.
And this is something we've been spending a lot of time discussing in our practice, and one of the things that's just an operational challenge is there aren't a lot of those people out there.
Correct.
And this is very high acuity care, and so you can't just hire one and expect them to provide 24/7 coverage.
But there's a group. So if you look at that statement, most of the co-authors that are not interventional cardiologists like me, they are dual-boarded. And there's a new breed of cardiologists that are getting, and more programs are opening. So I think we're at the beginning of the dual-boarded cardiac intensivist. And we're recruiting a new CSU directorate, and one of the requirements is that this director is dual-boarded because of the acuity of the patients.
Great. We have a question in the front here.
The question we have is, in our program, sometimes the patients in the emergency department and the emergency room doctors get the ball rolling, and we get down this path where we kind of are well into treating this patient, going to the cath lab because our door to balloon time initiative, and in retrospect, you feel like that patient should have never even gone to that because of their frailty index, or, I mean, what sort of things have you done in your program to try to, with education, or try to stop that process from being initiated to begin with? Any advice from that?
Well, we haven't done, so I mean, these are proposed models of care. It doesn't mean that we have them implemented all across the country. I think that different initiatives going on will end up implementing, and I think there's also leading initiatives from professional societies like American Heart Association. I am in charge of the acute care committee, and we're leading towards that. I think the model of care for this patient has to change. Whether or not you take your patient who is very sick to the cath lab, that's a decision that has to be made as a group, and depends on public reporting, depends on your willingness to take these patients, and depends on the resources you have available to take care of these patients. Sometimes you may want to refer these patients and develop a hub and develop relationships with a hub hospital that may take your sick patients. We transfer our sick patients that are in refractory shock across the street from our hospital. We can do up to Impella. We are implementing ECMO now. We have a traveling team that will deploy ECMO in my hospital and then transfer to Jackson, where the surgeons can take over the care and do more advanced and destination therapies or transplant.
Dr. Burke?
Thank you, Burke from Minneapolis Heart. A couple of comments on this. This is obviously our next big issue that we need to tackle, and it's imperative that we have procedures and protocols in place where not just cardiologists but intensivists and the ED physicians are all involved. We've started a program that we call SWAT, Shock Without Trauma, because so many of a third of shock patients are cardiogenic. So that means 2/3 of the patients don't have anything to do with the kind of things that I can do to make better. But we need to be able to identify those people better in the field so that they can be triaged appropriately. The other thing that I think that we need to do is we need to have a national initiative just exactly along the trauma lines. We need to have shock centers that have exactly level 1, level 2, level 3, exactly what they do for trauma, and have requirements for certain people in the house, certain abilities for different capabilities, and referral centers.
Yeah, and let me add to that. I think that there should be a single activation code when you have a patient with shock, so the whole team that concentrates the volume, the full team that concentrates volume will deploy and take care of that patient.
That's right. Actually, we have, with the Shock Without Trauma protocol, the patient is met by an intensivist and an ED physician in the ED, and the cardiologist is called if they believe that it's a cardiogenic shock type of process, so that the cardiologist can meet the patient in the ED as well.
Yeah,
So in our center, and this is called for action for all of us. First of all, there is a paper by Mauricio about the organization of cardiogenic shock. It's an amazing paper, really good. It's a must read for everybody who deals with cardiogenic shock. The other thing, you really have to look at your local resources, and the worst thing you can do is sit on a patient with the pressors. If you don't have escalation in your center, to ECMO and a VAD, you need to partner with a center that has an ECMO and a VAD. But the more important, most of our patients who transferred to us, they waited 24 hours to 2 days before they transfer. And by that time, the shock is not reversible. They have to move as soon as possible. The longer you wait, this is similar to the golden hour. I don't know if you guys, I used to be an ER doctor and I had ATLS, Advanced Trauma Life Support. There is a concept called the golden hour, meaning if the patient comes with a trauma, the best hour to save him is the first hour. After that, you cannot actually reverse the inflammatory process, the shock, all the other issues that could ensue, and the end organ damage. You have to act really fast. And the worst thing you can do is wait on those patients.
All right, it's been a fantastic discussion. I hope everyone enjoyed it and learned as much as I did. And we'll now take a break. Thanks to our panelists for enlightening us.